Vision 2020 USA presents the NASEM Report at 10 years, featuring Dr. Dean VanNasdale, Associate Professor at The Ohio State University College of Optometry. This presentation was recorded at Vision 2020 USA's reception held during the ARVO 2026 annual meeting.
So we'll get started here. Thank you for coming again to our Vision 2020 USA session. I think most of you know what Vision 2020 is, but I'm going to briefly go through what we've done in the last year here. And we're going to turn it over to Dean here, Dean VanNasdale, to talk a little bit about the NASEM Report and the 10th anniversary and sort of where we go forward. So thank you again for coming. Let's get started. All right, so we're going to go over the updates for the last year, and so here we go. So for those of you who don't know, Vision 2020, the Right First Sight, is a coalition of nearly 50 organizations that are based in the United States. They all have something to do with vision or eye health, includes government organizations, including the CDC, the NEI, includes professional organizations like all the ophthalmology, optometry professional organizations pretty much. And thank you. Oh, I have to share. Yep. So now everybody can see it. So this is kind of who we are, and we advocate. That's been done a lot, especially in the early years and in the last probably 5-10 years for change and policy. We educate each other and the communities that we engage with, and then raise awareness about the importance of vision and eye health in a land that is strewn with a lot of other competing interests like cancer and cardiovascular disease and neurological disease, things like that take place here. But we have a beautiful website with all this information. I just wanted to highlight a couple of things. So you don't have to read this whole paragraph. Please go to our website and you can read it more in detail. But this is something we put together this last year to capture the history. So Vision 2020, and we have some members of the IAPB here, the National Agency for Prevention of Blindness, and on Zoom as well. And they're the ones who sort of convened this Vision 2020 Right for Sight in the year 1999. So by 2020, they wanted to eradicate or at least dampen the causes of preventable blindness. And so that really took off. And it really took off around the world more than the United States. The United States was engaged with people in the United States who are working internationally and around the world. But those of us in the United States who are domestically focused really didn't know much about Vision 2020, the Right First Sight. And I actually learned about it through my contacts in India at the LV Prasad and Dr. G.N. Rao, who's a big proponent of that and was head of Vision 2020 for India and beyond. So and that was thanks to Sandy Block and Mitch Brinks, who really brought all that together. So that was really a turning point in Vision 2020's work. And there's a lot of advocacy, even almost a call to action by the Surgeon General. There was a meeting with the Surgeon General, but of course, 2019 was just before the advent of COVID, and that changed the game. So we keep going, we keep pushing forward. There was a letter to introduce an ambassador to the UN for vision. And so there's a lot of efforts around that. But when Dean and I took over, we were really interested into knowing more about what was going on in the United States. So when we took over at the end of 2023, 24, we had an executive committee, and we were working with this executive committee to kind of understand what they were doing. And we had started spotlights. We had this dialogue between all of the other champions of vision who were our members, and we kind of spotlighted what they were doing. So the focus was really on addressing health disparities and establishing health equity in access and uptake of eye care. And so that was really kind of the emphasis of what we're doing. I have a list here of today's executive committee, who is another dynamic group of people who are engaging in helping us carry their mission forward. So this showcasing initiatives to access care with relevance to the U.S. while learning from our global partners, including the IAPB, has been really a theme of what we've been doing going forward. The Spotlight webinars have been very well attended. We have a new website, we have a new logo, we have YouTube channel, we have all these spotlights on the YouTube as well. So basically, in person, we've had ARVO meetings on a few occasions, but our big ARVO meetings have been in 2024. Last year, we didn't have one because we had the IAPB meeting in Nepal around the same time, so many of us didn't attend ARVO. And of course, we have this one as well. We've also been at the Global Ophthalmology Summit, which is something that the American Academy of Ophthalmology is part of, but it is a separate entity, and that takes place usually in the summer, and we've been very much engaged in that. So if you all want to do a spotlight in what you're doing, please do email info at vision2020usa.org, and we would love to have you. So here's a showcase. I don't expect you to read this. It's on our website again. It's about 16 now spotlights in the last few years. So we really showcased a lot of what's going on in the United States. And a lot of these are on YouTube. And Dean has meticulously taken notes, and all of those should be online soon in some format. And I also want to highlight that we have a special session, thanks to the mentorship of Dr. Mitchell Brinks and others who have encouraged us, including Jeff Todd. We applied for a special session at ARVO, and we were selected. And this year's theme really stemmed from what was going on in the policy world. CMS said that, well, you know, I think we're going to pull back on the diabetes eye exam initiative, and we're not going to support that as part of the star ratings anymore. And we was like, why are they doing that? Well, actually, they got pushback from insurers. They got pushback from health insurers saying, hey, this is a hard metric to meet, you know, and we were meeting all the metrics so well. Otherwise, why are we graded on this one that, you know, it's been really challenging for various reasons to meet? So because a metric is hard, in my opinion, they just decided to get rid of it. And that produced an uproar, produced, you know, at least a lot of vocalization of opposition to that. And that resulted in CMS backing down and pulling back from doing that. And they no longer are going to take that away from the star rating. So that's a great win for all of us. And Vision 2020 was part of that initiative, along with other insurer colleagues and health advocates, including the American Academy of Ophthalmology and Optometry, who were really in support for keeping that metric. We have, so this is how this came about. And so we have an international array of panelists representing folks from the UK, from Australia, and also from the United States. We're going to talk about how we take this data that we have and how we make sure that it is valid and it is useful and it can be actionable. Because we can collect all the data you want in the world, we can do all the research you want in the world, but if it doesn't translate into actual better outcomes and better care, then we're really wasting our time. And so that's what this whole discussion is. And I hope you all come tomorrow at the Bluebird Ballroom from 1:15 to 2:45 to hear it out. So we had a meeting at Seattle in 2024. This is a research conference that we're at. And my last slide before I turn it over to Dean, just to reiterate what happened that time. So there was a lot of great discussion going on, but this was a poignant piece that actually one of the thought leaders, and I don't know exactly who it was, but I can guess, put out this statement that we really need to create an interagency work group. And this work group concept that comes out of the NASEM report, which is a recommendation number 4 of the NASEM recommendations that Dean will talk about in a minute, really talked about creating a common research agenda and coordinating eye and vision health research that and demonstration projects that are grant supported. So this is the population-based epidemiology, the population health services research, and the population health level research and development of emerging preventive screening technologies and care technologies. In fact, the clinical epidemiology group of ARVO has since turned into the clinical data science and population health section. So there's a lot of momentum along this route, and it echoes what the NASEM report has been saying. And with that, I want to turn it over to our resident expert on our executive committee on the NASEM report, Dr. Dean VanNasdale.
One of the things I was thinking about is Rajeev coordinates all of these things for the Vision 2020 group, is how diverse the expertise is like in this group, which I think is interesting. You've got clinical people, both from optometry and ophthalmology, working together because they see common objectives. You see people from nonprofit organizations also contributing and supporting a lot of the work that we're doing. And each group brings different expertise to the table. And what I thought would be really important is to think about how can we bring all this expertise together so that we're not reinventing the wheel, we're working a little bit, hopefully more efficiently, and then highlighting a lot of the stuff that's being done. So I think trying to get, in particular, this group together to work in a more coordinated way, we can start to, I think, accomplish some of the goals that the NASEM report set out 10 years ago that haven't been completed yet. And so if anybody had a chance to listen to the most recent Vision 2020 webinar, John Cruz talked a little bit about his experience in the NASEM report and how much work it took leading up to the NASEM report. There were a lot of things that people had been sort of discussing prior to the 2016 report coming out. And one of the things that had come out was a special issue in the American Journal of Ophthalmology where people were talking about some of the same things that we're talking about today, the need to standardize health surveillance outcomes and ways to address sort of unmet need in the population. And so some of the things that came out of this special issue of the American Journal of Ophthalmology, I think were really influential when people were starting to form ideas to sort of develop this NASEM report. And the CDC for a long time has had this sort of framework that they use where it's sort of this sort of pie-shaped circular process where I use this slide a lot because I think it's a good way to think about what we've done and what we need to still do. But what you've got are these sort of essential services in public health where you start at the sort of 1 o'clock position of this pie diagram, monitoring health, and then you go to diagnosing and investigating problems, informing, educating, empowering, mobilizing community partnerships, developing policies, enforcing laws. And then you get to about 8 o'clock, you've got link to and provide care. And then like 10 o'clock, assuring a competent workforce. And then it's sort of this 11 o'clock position, evaluate. And this is sort of an iterative process, right? You sort of monitor health, figure out what you need to do, try to put policies in place, ensure that those policies are being enforced. But then at the end, you have to evaluate and see whether or not you accomplish the goals that you set out to do. And I think that the evaluation piece sort of gets missed a lot. So I think people start to put policies in place where they have sort of, I think, an assumption of what the outcome is going to be, but never go back to actually quantify and see whether or not it actually helped. And so I think that a lot of the people here, I think, are seeing or understand the shortcomings of some of the things that have been put in place and some of the work that still needs to be done because they've actually sort of evaluated where we're at. And in the NASEM report, what they did was they took this model and they sort of split it out into sort of, instead of a two-dimensional circle, they sort of split it out into sort of this three-dimensional cylinder. And what they did was they talked about how this model actually applies to different levels of health prevention, ranging from what people had historically used to describe preventive services as like primary, secondary, and tertiary, primary being more like educational services, secondary being things like screening, and then tertiary being clinical care. But one of the things I thought was really unique about the NASEM report is they understood that there's more upstream influences that people weren't formally sort of quantifying or qualifying. And so looking at things like primordial prevention was something that the NASEM report thought was really important. So they added this primordial prevention on top of this primary, secondary, and tertiary prevention strategies that the CDC commonly refers to. And primordial prevention is trying to also work in more sort of environmental and social circumstances to improve healthcare outcomes. And I think that when I thought about the different groups and individuals who have been really active in Vision 2020, one of the things that I started to realize is that we've got people who are working in each one of these different categories that have been sort of outlined by the NASEM report, but oftentimes people are working in these categories sort of independently, and there isn't like a lot of talk among the people who may be doing some of the primary prevention with the people who are doing some of the tertiary prevention, where the primary prevention could potentially really reduce the number of bad health outcomes that the tertiary prevention strategies have to address. And so trying to think about how do we look at these things more upstream and how do we communicate across these different prevention strategies better with people who are sort of the experts, I think that there's not a better group than the Vision 2020 group to start sort of thinking about this. And when this came out in the NASEM report, I think that 10 years ago, there was a lot of, I think, attention paid to the NASEM report. Now that we're sort of 10 years out from that, I think the attention to the NASEM report is starting to fade a little bit. And so I've been talking to both Rajeev and people like John Cruz, trying to figure out, okay, if we want to sort of start to gain a little bit more momentum again after 10 years of the NASEM report release, what are some of the things that we should do? And so one of the things that John Cruz sort of encouraged me to do as well, go back and look at the content of the NASEM report and sort of see what's been done and what hasn't been done. So if you look at the content of the NASEM report, it's divided up into chapters, and these are each of the different chapters that show up in there. And so you've got understanding the epidemiology of vision loss in the US. So you're talking about things like health surveillance and how do we measure the magnitude of the issue among the population. And it's, I think, a lot more complicated than people might think. And I think when you think about the epidemiology of vision loss, looking at some of the people like David Ryan and John Wittenborn, who are at NORC, who put together the Vision Eye Health Surveillance System, is one way to sort of understand how complex our vision health surveillance system is. And both of them also gave a Vision 2020 webinar a few months ago and outlined sort of what they had done already, but also what some of the newer things were that were about to come online. And one of the things that they've been focused on was coming up with ways to assess vision impairment on a scale that's geographically granular enough that you can actually potentially do something about it. So looking at differences or disparities in vision impairment at sort of the zip code level. So now you've got sort of tools where you can say, okay, these populations are sort of disproportionately impacted. What is it that's different about these populations where we could potentially make a difference? So some of the people that we've heard from already and some of the webinars, I think, have provided some unique insight. And I think the other thing that's good about the webinars is that people tend to leave us with specific resources or things that they think are particularly helpful. And I think, you know, having the ability to sort of talk to some of these people and learn from them, I think, has been particularly important. And one of the things that we also look at is sort of like the impact of vision loss. So what are the health consequences, not just from vision loss as sort of a standalone condition, but vision loss is potentially a comorbidity too, because a lot of the things that the CDC has looked at in the past has not been vision by itself, but how often is vision occurring with things like arthritis, diabetes, and things like that, things that we know are happening in combination and are sort of amplifying the effect. And then surveillance and research, and this is just going back to sort of how do we use the surveillance to assess the population and learn about some of the disparities and some of the determinants too. And when people are starting to use some of the surveillance research, I think people are starting to look at vision impairment not only as sort of a health outcome, but people more and more are starting to talk about the bidirectional nature of vision impairment. So there are things that influence whether or not people become visually impaired. But if you think about it, vision impairment also influences whether or not people have other sort of poor health outcomes. So thinking about vision more broadly through some of the surveillance research, we can start to see more and more that vision shouldn't be thought of solely as a health outcome, but something that's potentially impacting other chronic conditions and impacting people's health-related quality of life. And then the role of public health partnerships to promote eye and vision health in communities. And I think there's a lot of good people who are doing work in this group that have given talks in some of the webinars that talk about their specific communities and how they're trying to address some of the unmet vision care need. But I think you also have, when you're looking at people who are developing really important partnerships, I think you've got people like Prevent Blindness that have for a really long time promoted a lot of different partnerships. Also work on developing content that's sort of more primary prevention and educational in nature, stuff that I think a lot of us probably aren't using as much as we potentially could, because they've got a wealth of resources there that I think we could use to better educate the population on the importance of vision health. And then you've got things like access to clinical services, workforce and coverage. I think one of the things that you look at a lot of the previous workforce studies that have been done in the vision community, they look at the workforce sort of on a national scale. And I think the more access we have to geographically granular data, I think one of the things that we need to start thinking about is even within sort of the US or even within individual states, there's a lot of disparities with respect to the prevalence of vision impairment. And so we have to think about how do we get workforce in those areas so that we can cover some of the services that we might be missing. So I'm from Ohio. In Southeast Ohio, if anybody's seen a map of Southeast Ohio, all the health metrics and outcomes down there are pretty bad. And if you start to look at, okay, well, what are some of the influencing factors? One of the things that's a problem is you don't have any vision care providers in there. So when you see high rates of vision impairment in Southeast Ohio, it shouldn't be a surprise because there's no vision care providers there to deliver services that are going to prevent people from becoming visually impaired. So people are starting to think about what kind of other, if we don't have in-person providers there, what other things do we need to think about to be able to address some of those issues? And so some of the people who talked on some of the webinars have talked about their work in like the VA system and teleophthalmology and things like that. So I think that learning from those people and what works and what doesn't in specific systems, I think has been also enlightening. And then I think some of the things that get left sort of out of the conversation are things like vision rehabilitation. So inevitably, we're going to have people who are going to experience vision loss. When we have people who experience vision loss that's uncorrectable, what kind of options do we have to be able to address that? And so I think one of those things that we have to start thinking about is how do we do a better job of integrating vision rehabilitation services and some things that we provide, and where are those people at the table when we have meetings like this, because we don't hear as much from the vision rehabilitation community. And if you look at some of the national health objectives, things like Healthy People 2030, you'll see that access and utilization to those services is extremely low. And then the NASEM report concludes with recommendations and a path to action. And so I started to look through some of the recommendations a little while ago, and John Cruz, when he talked on this topic a couple weeks ago, went through these also, noting that as he went through these and hasn't gone through them in the recent past, what he realized is there's still a lot of work to do. These recommendations tell us what we should be doing 10 years ago. Where we're at now is probably not where he had anticipated that we would be when this report first came out. And so things that I think we could focus on is something like calls to action. This was one of the recommendations to eliminate correctable vision loss by 2030. And we're quickly approaching 2030 and we're probably nowhere near that goal, right? So we've got sort of a lot of work to do there. Launch coordinated public awareness campaigns to promote policies and practices to encourage vision and eye health across the lifespan. I think that there's a lot of content that's out there from different groups that's I think particularly impactful, but we have to get that information out to the public and the people who actually need to be able to sort of get those resources so they understand the importance of preventative eye care and what to do when they have specific conditions. I'm thinking specifically, there's a lot of stuff that the National Eye Institute, CDC, National Eye Health Education Program, which is sort of the educational arm through the National Eye Institute, has really good resources. And I think that Prevent Blindness has done a good job of consolidating a lot of those resources in one location. But I don't know that a lot of people know that some of those resources are out there. So I think we have to probably do a better job as a group of making sure that people understand that. And then CDC should develop coordinated surveillance system for vision and eye health. I think the group at NORC has done a pretty good job of making some significant progress in that, but I think that there's still work to do. Interagency work groups, this is something that Rajeev had mentioned already, to address sort of the leading causes of vision impairment. And CDC for a while had demonstration grant programs that were available to different states. And so for several years, we had some of those grants where we were looking at epidemiology data in the state of Ohio, and different states had different projects. And I thought those were particularly helpful, at least in Ohio, for helping us develop a data set that made it easier to demonstrate to policymakers why vision impairment is something that they should care about. And then things like HHS and other groups should develop a single set of evidence-based clinical and rehabilitation interventions. I think that one's going to be probably a tricky one to do. I think that probably if you look at the guidelines, the clinical guidelines between optometry and ophthalmology and vision rehabilitation, some of those are not going to align terribly well, but I think at least we can have objective conversations with the group that's here between optometry, ophthalmology, potentially vision rehab people in nonprofit on, okay, what kind of evidence-based guidelines can we agree on? And I think that this is a unique group that might be able to have that conversation. And then enable healthcare and public health workforce to meet eye care needs of a changing population. And I think that through some of the members of this group, their discussions on how they're addressing community-specific needs has been particularly helpful, because I think if we're all trying to do this in a very fragmented way, people are going to be using a lot of resources unnecessarily to reinvent the wheel. I think we can learn from each other. We can do a better job of ensuring that the workforce might be able to meet the need. And then state and local public health departments should partner with healthcare systems to align public health and clinical practice objectives. And I think what is important for this point is that there's, I think coming up with ways where we can do a better job of assessing what's happening at the community level is going to be really important, because I think the interventions that are going to have to take place if we want to meet some of the goals that we have for reducing vision impairment are going to require things that involve the community itself, and are going to have to be community specific. So interventions in one community probably aren't generalizable to every other community. And I think we have to understand those dynamics a little bit better. Identify and eliminate barriers to healthcare systems. I personally think that there's lots of people that are doing really good work. I think that some people using community health centers as ways to reach medically underserved populations that are high risk for poor vision outcomes turns out to be really important. And then having eye and vision experts in decision-making bodies, I think, is going to be super important too, because I think that the eye gets overlooked. But I think people are starting to recognize more and more. I mean, it's a little bit cliche. People talk about the eye being the window to the soul. But if anybody sat in on Michael Chang's talk earlier today, one of the things that he was talking about is how people are starting to recognize the importance of the eye because of the things that you can see in the eye that are systemic in nature. So it's not just vision specific anymore. So I think making sure that decision-making bodies understand that turns out to be really important, because that gives us a lot more leverage. And then encouraging physicians, healthcare providers to engage in address vision health issues. I think people in primary care are very interested in trying to do a better job of getting their patients engaged in vision care services. I think they just don't always know how. So I think that that's a responsibility that we have to figure out ways where we can do a better job of engaging other healthcare disciplines. CDC prioritizing and expanding vision grant programs to build state level capacity. I think this is going to be a little bit challenging because the CDC and Vision Health Initiative doesn't have a huge budget, and that budget's always at risk. And I'm always worried that it could go away at any time. And currently, as far as I know, there's only one person that's full-time in the Vision Health Initiative. And so that's sort of scary. If you think about the entire CDC, you've got one person who's in charge of the Vision Health Initiative, and his background, I believe, is in family practice. And so I think one of the things that we have to do is people who have been working in vision for longer to make sure that we can advocate for the CDC and try to help get more capacity for some of the things that they're doing. So ideally, they could have a larger budget to help support other state and local capacity building programs. And I think some of the work that's been done through the programs that they've done in the past have been particularly impactful. They've got a toolkit that they've put online that outlines some of the stuff that some of the grantees have done in the past. And so I think that we should be trying to encourage them to do more things like that. And then getting communities to work with state and local health departments to translate a broad national agenda, I think is going to be important. Raising awareness, I think, is huge, because if you ask people why they haven't got their vision checked in the past year, for people who haven't got their vision checked, their number one reason is they didn't think that there's any reason to go. And so that's a problem, right? Because a lot of the things that are potentially vision threatening are going to be things that are going to be asymptomatic in their earliest stages, and the public and policymakers aren't going to, I think, intuitively realize that. So I think improving eye health awareness is going to be really important. And then looking at back to sort of community level barriers, I think we're going to have people who are familiar with different communities that are at high risk and having some sort of way to be able to sort of diagnose some of the barriers to care. And then addressing built environments and policy environments to promote eye health. This goes back to the point that Rajeev was making, right? If Medicare is thinking about getting rid of a vision objective that is potentially going to be meaningful to not only the vision community, but people who are at high risk for vision loss from things like diabetes, then I think that we have to be a group that's fairly sort of mobile and be able to identify and address some of those problems as they come up. And John Cruz in his webinar mentioned the fact that while the NASEM report itself is fairly comprehensive, they couldn't possibly fit all of the topics into one report. So there are some things that didn't get as much attention as he thought it might need. So there wasn't a whole lot of emphasis on pediatric care in the scope of work from the NASEM report that came out 10 years ago, or vision rehabilitation. What a model of an ideal vision and eye health system should potentially look like. We need a better understanding of capacity of survey questions to capture the population of interest. If you look at, and David Ryan and John Wittenborn talked about this a little bit, if you look at some of the data that we primarily collect vision health surveillance data through surveys. We ask people whether or not they are blind or have serious difficulty seeing even when wearing their glasses. So that's a question that gets asked both in the American Community Survey and the Behavioral Risk Factor Surveillance System. The problem is if you look at the prevalence rates or the estimates from each of those two, even though you ask people the same question, the prevalence rates turn out to be different. So it's really difficult to come up with a single number of how many people are visually impaired. So we need to understand how these questions work and what kind of other data we need to get to come up with an estimate of vision impairment in a way that's sort of meaningful, not only for us, but for policymakers. And then developing sort of a more standardized research agenda that could be scalable and exported to sort of different locations. And if you think about how some of the things that came out of the NASEM report 10 years ago align with the Healthy People Initiative, Healthy People 2030, if anybody doesn't know, Healthy People is sort of this 10-year ongoing set of objectives that get set. You have baseline data, 10 years later, you look and see whether or not you met your objectives. And the good thing about it is that this is sort of a nationally recognized set of health priorities. And within Healthy People 2030, you've got things that look at diabetes and vision impairment. These things don't happen sort of in isolation, right? People who are visually impaired, lots of them are going to be diabetic. So you have to sort of think about how these things work in combination and what the trajectory looks like going forward. So if you look at the stuff that comes out of the NEI, they're looking at projections between 2010 and 2050 of a doubling of each of the age-related eye diseases. And one of the things that's particularly troubling, and Rajeev mentions this frequently, because I think this is one of the sources of his greatest frustration, is that by the time they see a retina specialist like Rajeev, they're in pretty bad shape. And a lot of that could have been prevented if it had been caught early and managed effectively. And so the numbers that come out of CDC and NEI would suggest that there's a lot we could do to reduce vision impairment from some of these sight-threatening conditions that are going to cause irreversible vision loss. And for diabetes, that's a 95% reduced risk of vision loss. So there's lots of things that we could do, and I think a coordinated effort among this group could help us get there for sure. And then when you look at the Healthy People 2030 work group, they've got 14 objectives, 19 of them are quantifiable currently. They have 8 with baseline data, even though they've collected these data through like Healthy People 2020. The way they've sort of changed the way they track things has changed a bit. So if you look, only 8 of them for Healthy People 2030 are considered to have baseline. One of them, I think, reduced the prevalence of vision impairment in the pediatric population, is the one that has baseline data plus some updated data. And the last time I checked, that objective hadn't changed much, even though we're halfway through our Healthy People 2030 cycle. And then you've got a couple of developmental objectives. and some research objectives. One of those is looking at how to get more vision care services into things like federally qualified health centers, which I think is something that people here recognize the importance of. And if you look at some of the objectives, not all of them are captured in the vision work group. So on the top here, you've got the D-4, increase the proportion of adults with diabetes who have a yearly eye exam. This actually doesn't come from the vision work group. This comes from the diabetes work group. And if you look at where we're at, this is, I looked at this a couple months ago. When I did, little or no change from our objective. We've got the most recent data from 2023 would suggest that 66% of people, adults with diagnosed diabetes, have had an eye exam in the past 12 months. And you can imagine that the people who aren't getting eye exams who are diabetic, those are going to be the people who have sort of the worst health outcomes likely. And then looking at their objectives, so the vision objective, reducing vision loss from diabetic retinopathy is sort of inherently tied to this proportion of adults who have yearly eye exams. And if we look at the numbers, we could probably, the numbers aren't super ambitious. We could probably do better if vision impairment from diabetic retinopathy can be reduced by 95%. And I think the people here, both the clinical care providers and the people who do a lot of the advocacy work, I think we could do a lot in a coordinated way to make a better impact on some of these national health objectives that we have. And then because if you also look at things coming out of the diabetes work group, increasing the proportion of people with diabetes who get formal diabetes education, we've got like educational material available, right? That's vision specific. So we could actually try to get this number up by trying to disseminate this information a little bit better. And I think that we have different networks where we would be able to do that a little more efficiently. So sort of thinking about this across this sort of entire spectrum of prevention, from primordial prevention to tertiary prevention, at 10 years from the NASEM report, I think a couple of the things that we could do as a group is try to figure out what the member priorities are in Vision 2020, and what we think the role of Vision 2020 should be. I think we should catalog some of the work of the members and develop a repository. That's, I think, what we've been doing with some of the webinar work. And then how do we disseminate this work and some of the ideas that we have across sort of larger groups? And that's, I think, where John came up with this idea not too long ago, because this has been done by other groups. A NASEM report gets released, and then several years later, when it's starting to fall off people's radar, they sort of have an update, put together like a workshop where they bring people together and sort of discuss where we're at now and what needs to be done next. And so John recommended that we think about coordinating efforts and try to think about ways where we could potentially put together a NASEM workshop. And then as part of the NASEM workshop, one of the things that we could do is write a number of different papers in a coordinated way among the group that would get disseminated, and that would be a little bit more high profile than the stuff that we can do individually. And this just talks about a little bit about the NASEM workshop as a possible mechanism of more efficiently getting some of the information that we know within this group out to a broader audience. And I think that would help reduce some of the fragmentation that we see, because there's lots of people that are doing like really great work in this room, and a lot of it, I think we could learn from each other so that we can make, when you're looking at trying to put together interventions with relatively limited public health resources, the more that we can learn from each other, the more efficiently we could use some of those resources. And then with a work group, we could also sort of set some goals for future initiatives too. And then one of the things that Rajeev and Hossein have done is put together sort of a member survey to figure out sort of what the priorities are of the group. And so I've put a QR code up for anybody who wants to take the survey and provide some input and feedback. But I think that's one of the things that we should do is sort of take a look at, okay, 10 years ago, what were our goals? What were the things that we hoped that we would achieve? What did the landscape look like? And then taking a look now, 10 years later, to say, okay, where were we successful and where do we still have work to do? I think would be good at trying to sort of guide our work in the future. Okay, and if anybody has any questions, don't ever hesitate to send me an email. I'm happy to answer questions at any time.
Awesome. That survey is also on their website too, but there's been a request for the people online, because they can't really see you too well, to just go around the room really quick and to introduce yourself. So I'm Rajeev Ramchandran. I'm a vitreoretinal surgeon at the University of Rochester. I chair Vision 2020 for the last 3 years.
My name is Stephen VanNasdale. I'm a faculty member at Ohio State University in the College of Optometry, and I've been working with Rajeev for the past couple of years at Vision 2020 USA, and also done some work looking at population health surveillance data.
Any questions, any comments out there?
We're going to make just a quick comment, and then I also wanted to make one on behalf of IAPB. I was just texted about the CDC discussion that you shared. The National Institute is currently funded at around $900 million, which is great and probably less than they really need. The CDC's Vision Health Initiative was funded at $6.5 million, and $2 million of that got cut. So, that's a third of their budget. And I mentioned they have one staff person. I think last year, the eye care community did a great job, and rightfully so, of rallying around the National Eye Institute, because we were worried it was going to go away. We were worried that the funding was going to drop. Luckily, we were able to save that, but we need to continue and work hard at that. But I think we should also turn our attention to the CDC at the same time. Losing $2 million of a $6 million budget is kind of pathetic. I don't know, putting that on us, but I think that we need to be more vocal about that, so that so much of this work can be advanced. But then also Jude had asked me, who is called in from Australia, to give a little update on the Global Eye Health Summit. There's going to, and this is as opposed to the Global Ophthalmology Summit, this is going to be a summit taking place in November. IAPB is helping coordinate it. It's going to be the invitations are coming from the countries of Antigua, Barbuda, and I think Nigeria maybe signed on. In Malaysia might be signing on. Anyway, the point of this is that what they're trying to do is to get heads of state from all around the world to come to this summit. Frankly, the U.S. is very likely not going to be there. It's the day before our midterm elections. I can't imagine anyone from the U.S. is going to fly to the Caribbean the day before our election. But what we are really trying to do are get governments and heads of states to make commitments to global eye health, global and domestic. And so many of the things that you listed here, and I've been thinking about some other things, but so many of these things could be turned into commitments. If we can get the U.S. to say we commit to eye health and we commit to doing A, B, C, and D, that's a strong message if we can say that in front of the global community. So I'm working, as I said, I'm in the North American chair, so I'm working to help IAPB gather some of these commitments. But I'd love to talk with folks about how we can all work together to get the U.S. government to make even one or two of these commitments to eye health that they could put on paper. So happy to have that conversation at some point.
Thanks, Dan, and thanks for bringing John Cruz to the webinar a couple weeks ago. That was great. I think John's online. So he had a lot of interesting background on putting together the NASEM reports, and I'll just make a couple of comments historically that using that report really propelled the advocacy world and vision health forward quite a lot. I happen to kind of land in the chair role of Vision 2020, and I'd point to that report and I'd have credibility and really a well thought out canon of what should be done in the U.S., which was hard to kind of countervail, with kind of lesser arguments. So it was really, really powerful. I think that led us to the meeting with the Surgeon General and nearly a call to action. And thanks for all your support with that, Prevent Blindness as well. I think it only was the pandemic that obstructed that call to action, which would have, I think, led to some downstream benefits of potentially getting HHS and other federal agencies to kind of have a more unified approach, which seems to be the common underlying theme here. We kind of a relatively small community. John called us a country club. We're so rare. In a big, vast country like this, it's easy to get isolated and not be complementary. So I think there'd be a lot of potential of a repeat NASEM report if that were to happen. And I think there's a lot of steps that I don't really comprehend, but his opening the door is pretty exciting. And this kind of organization, I think in my other observations historically, is that with great organizations like Prevent Blindness, it represents the stakeholder community for the U.S. in a way that few other organizations do. If you're the AE ophthalmology, you're a giant organization, but your ophthalmology, or your optometry, this organization can represent all the vision care organizations pretty well. And that meets a need for federal agencies not to try to divine what the community is thinking and anticipate conflicts in the future. We do that work ahead of time. So there's heaps of potential in this organization. So I think that there's a lot of potential here and a lot to think about. And one other thing John mentioned that I guess I'm channeling John here, but he mentioned, I think he said models of care, to define ideal models of care, because what might work in Michigan might be different in Oregon, might be different in Newark or, the Southwest, but that's not really done. I mean, Pollyanna's done lead work in the country, in Michigan alone, could be 30 of us doing that and thinking about how that might be adapted to different environments, which wouldn't be reinventing the wheel. It'd just be thinking about all these different wheels that have been invented around the country, work together in a system. And my last kind of editorial comment is, I know Mike Ching very well. I listened to that National Institute presentation today. He's doing brilliant things. We're so lucky he's there. He really understands us. He helped prepare that work for the Surgeon General years ago. But, he in the future, like data science and technology, regenerative medicine, that kind of thing, it seems like there's a gap that we're trying to fill here, because the National Institute and the NIH often fall into that deep bench in clinical research. The CDC, with less than 0.5% of that budget, tries to do everything else, translating that to the population. And so this group potentially fills a role in kind of bridging that gap, or pulling the National Institute with their giant budget in that direction. I mean, I think they have to respond to stakeholder coalition entities if we present a well-founded and thoughtful presentation or proposal to them. So I think there's some room to work in that area. That's my thoughts.
I think also really work that Dr. Chang has done to bring the National Eye Institute into the public health prevention space over the last few years. And if anyone's read their current draft of their strategic plan, I'm seeing more and more of that. So, but that's not to say we don't want that at the CDC too.
So I have a question for our resident IAPB member expert here you've worked in a lot of different environments, a lot of different countries. The United States has established, organizations that champion vision or supposed to be champion vision, but they get pigeonholed in their own different areas. A lot of times in the developing world, especially, there's nothing there, and you kind of invent everything. Like my, example is LV Prasad, who just creates everything, and they create from the education on up, and they can do everything because they create everything. How do you work in a setting that already has the brick and mortar stuff in place, the organizational structures in place? How do you work in that type of environment? Maybe Australia is a particular example that already has some of this, to create this vision coalition and be relevant in a setting where people already sort of have their own agendas often. Sorry, are you asking how, from an IPB perspective, to work in more established high-income urban settings? Yes. That's a tough question. I thought you were going to ask the reverse. No, because all our folks, here, that's why this was created, we're working outside, and they were making a lot of gains. But when the people outside would come and visit me, they would look in their backyard and see all these people who were homeless, who were going out vision care, didn't get health insurance. Like, why are you coming out and teaching us the world? You guys have problems in your own backyard. Why are you doing that, right? So we need to answer that question, right? And that's like the $50 million question of how do we address that? And being from one of the developed countries, how do you see that kind of playing out in your own backyard? I mean, I think it's so interesting when you have all of those inequities that happen in those high income settings, and being able to
have the data to demonstrate that is critical from, globally, whether that equity is, within states or between states or in cities. So I think that's one of those applicable data challenges that is everywhere. Being able to really demonstrate those inequities. Sometimes that is less accepted as of interest. It's not of interest everywhere. I think there's also really lots of challenges in the way that eye health is financed. US seems to be incredibly complicated in the way that all the states and all of that financing exists. Just going back to the NASEM report, I think it's an amazing report, and I wish I was more familiar with it, because I think the way that you've conceptualized the way that data is needed from the circle of data around assessment and policy development and assurance is just a fundamental aspect of the way that data is needed in establishing priorities and demonstrating value and demonstrating impact. So I think that, is an essential componentry of how you analyze and show progress and prioritize eye health. But I agree it's incredibly challenging when you have lots of infrastructure and lots of inequities and lots of really complicated financing. So I'm sorry if I don't have a really good answer.
If it were that easy, it would all have been answered. So that's it. Any other questions, comments?
So it's interesting to think about having served on both that NASEM work group as well as the more recent one that looked at myopia. And thinking about, and particularly with the more recent one in myopia, coming out, one of the main things in that report is we said myopia has to be thought of as a disease. And when we think about myopia as a disease, building on something that Anthea had just said, if we really thought about myopia as a disease and how we should treat eye care compared to all the other things we have for healthcare financing and health insurance, why isn't it covered just as part of everything else? And particularly once you have that no pun intended, but that lens with myopia as a disease, and thinking about all the interrelationships, and Michael Chang talks about this quite a bit as well, between eye health and systemic health back to eye health. And I saw a poster today about, looking at how people for DME getting delayed anti-VEGF care because they had other hospitalizations. And the person was focusing on continuity of care. And one of the things that if we begin to think about the eye as not just something else, but a part of the body where we should just think of it as part of our overall health, is that continuity of care isn't disease by disease. Continuity of care is continuous integrated care for the whole person. And thinking about, what happens when, if we were to find a way to set up a system where the financing was clear, we thought about it as, another part of the body that needs to be thought about, cared for, managed in a way that would be much more like managing other diseases, as opposed to those of us who grew up in the 80s and had increasing myopia. Well, you just wait until you can't see again, you go back to the optometrist and get your next pair of glasses without much thought as to what it means to your long-term eye health. But there's so many opportunities to really think about not just a system for eye care, but a system for how eye care fits into a larger health system that maybe could work better. But that's a really big goal, and we have a hard enough time just getting a better system for eye care itself.
So has anyone quantified the health economics? So I know we've quantified like the health economics of vision loss. Has anyone looked at kind of the health economic aspects of, like, to tease apart eye health, like vision impairment on other health outcomes?
That's a great question, and I don't think anyone has. At a recent meeting that Research to Prevent Blindness had sponsored, Michael Chang was talking about, how research on the eye can then be multiplied into research on other things. And we've made multiple comments about eye health and greater systemic health. And I think what would be really interesting, if you don't have proper reading glasses and you can't read your prescription, and how does that affect you? The classic story, if you don't have proper reading glasses and you can't do your job, how does that affect you? There are impacts on economics, there are impacts on health, there are impacts on injury. And so, what is that multiplier effect? You give someone glasses and you take care of the simple thing, that they can now see where they're going, they can watch, they can consume more information in the environment, all of that sort of thing. But how do we put a much broader monetary value on that to truly represent, as you add, the impacts on health, the impacts on well-being much more generally? And it's hard, and a lot of it would be just sort of cobbling together the best that we can. But it would definitely begin to demonstrate this, return on investment, and as I like to call it, a multiplier effect of having better eye health.
That brings up the point where you talk about the economics, right? You talk about the money, where show me the money and show you where the treatments are. So a lot of the issues that we see are addressed because there's money behind it, right? The research is done because there's money behind it. So, where does a group like Vision 2020 or these coalitions, where do we find that money? Where do we draw from that money? And who has the pockets to pay for this? Well, maybe one of those is industry, right? And maybe industry can help us, and support us in this effort to bring everybody together.
That would be wonderful. I have not seen that in the past. I have not seen a lot of industry support for community health programs, but if industry was willing to partner more intensively in this space, I think that would be really wonderful. Because there's two problems, right? There's the personnel so there's your capital costs, which would be great and then you have your personnel costs. And a lot of places can't afford the capital costs, and they also can't afford the personnel costs. But at least I think if industry was willing to play a role in capital costs, that would make a huge impact.
So I'm the only industry person in here. It's about how industry can support initiatives, right? And paying for capital costs is challenging at times. There's grants and different processes for us to be able to support initiatives. And that's one reason I'm here, is to talk about local screening initiatives. And in Rafa, for example. So I think there's a lot of opportunity, and certainly Genentech is very interested in engaging this front. I heard some information on zip codes and population health data. Really excited to learn more about that, what's available from Vision 2020 or other resources. We really want to target populations that are underserved, who need screening initiatives and support initiatives. So I think I'm happy to put you in touch with other Genentech people and share my information with you as well.
And that's right. It's great to hang out with here, and with colleagues from around the country have also sort of been more engaging in talking about this. I know Mitch has been talking to national leaders from Genentech and other groups as well. But how about a group that addresses the underserved? The Association for Clinicians of Underserved. We have Luke Erdl here, who's the vision section head there and the program director. Can you tell us a little bit about your experience? I mean, you coming from an area outside of the world of eye care directly, and how does this all apply to what you're doing?
It's connecting a lot of the dots. I don't have a background in eye care. I have a master's in public health, so it's helping to piece together a lot of the different parts and things like that. Specifics around eye care, but it's giving a lot. It's making a lot of these connections because this is looking more globally as opposed to just with FQHCs. But FQHCs are a piece of that puzzle and a piece of the NASEM Report puzzle. So I think that there's need for conversation of FQHCs in amongst all this, since they are the first access point or maybe only access point for a lot of people that aren't getting access to care. A little bit like Paula Newman case was saying, the capital part. That's health centers don't always have the money laying around to be able to purchase the equipment. That's one of the main things. And then also the other hoop is finding a doctor. Those are I think the two main things that FQHCs struggle with in this space.
The other thing with all of that is you can throw money at something, but if you don't have the right implementation, and I know Kristen left, but she's all about implementation science too, and that's the key thing. You can throw money at the issue, but if you don't have the right program, right approach, that will be a big problem as well. Here.
Yeah, so I think a lot of these research that's been done in certain centers that are showing a lot of good results can be then implemented in other centers so that each center is not redoing everything. And I think making sure that, for example, using say the emergency room as an example, a lot of people go to the emergency room and they go with eye problems, and then they have to get an appointment to see an ophthalmologist. I think one of the things that we should possibly think about is just as how you have emergency room physicians and hospitalists, we should start thinking about getting an ophthalmologist or an eye care provider embedded in the hospital setting, so that when these patients come in, at least they can be seen and be diagnosed. And I think each emergency room should be equipped, just as though they have X-ray machines, that they should be equipped with certain basic eye equipment, so that at least they can be diagnosed, so that you can at least catch them. So I think there's certain things that will not change, but there's things that we can do to, using telehealth, so that when they come in, we can get pictures and send it to different ophthalmologists. And so, because we're not going to overnight get enough ophthalmologists and optometrists to cover everyone. But we have to come up with methods that work, that are shown to be that are shown to be show good results, and from whatever models, whichever centers you get it from, and then try to create a model so that you can implement it in other places.
That's a great point. So what about ophthalmic technicians? One of the things they've done in the developing world, especially, is that they've empowered people who don't have much training in eyes to learn the basic skills to become ophthalmic technicians. Jacopo is there to train folks who are ophthalmic technicians. Could you deploy them out in the field and to use them to be the screeners, to be the ones to have the diagnostic capabilities, and then connect them via telehealth or some type of technology to those who have expertise, right? So distribute that expertise knowledge. And industry again has understood this, right? So especially in the optometry world, there are a lot of teleoptometry going on. Like I get referrals for Optos images that have specks of blood or whatever all the time from people who are not seeing an optometrist in their own facility, but seeing an optometrist remotely through these cameras, through this technology that are in New York State, but not in the city of Rochester. So would that be a way to expand this? Any ideas about that workforce?
I know I don't have the long-term experience maybe all of you have, but as an Army optometrist, I have experience deploying to places where people don't want to go. And we have people sign contracts and we throw them in jail if they don't go, right? That's the best way to get people to go places they don't want to go. So I don't think you're going to have a better, it's hard to, I love the idea of we just train more people and then they'll go, right? But if we don't have incentives in place to get them to go to these low access areas, those people aren't going to go either. And so I think we have a great foothold with our federally qualified health centers that if no matter who we're sending, it doesn't really matter. If we don't have a foothold for them to go and incentives for them to stay, that we're still going to have these low access areas. And so until we have incentives for providers of any type to be in those places, it's not going to happen. And I know Dr. VanNasdale talks a lot about we need federal incentives for people, loan repayments, special payment processes. That provider. I mean, when you look at workforce analysis, we have enough IT providers in the United States.
One quick thing on to that, then also, I feel provided for and that's the point, is I care part of healthcare, right? Insurance deals with that, right? We always diabetes, I can cover the refraction that patient needs is not covered. So, the patient comes to get glasses, and that's fine.
So the patient comes to you to get eyeglasses to get their vision checked, but you find some other issue in the eye that you're more interested in, right? So you have to kind of meet the patient where they are. So how do we address that? As an organization, as Vision 2020, do we go to CMS and lobby for that? I think glasses was a provision that was I think it was Biden's term. They were trying to kind of get that in, but that kind of fell through because of the cost. But any thoughts about that? I don't know. This group has been pretty advocate for a lot of things in the channel.
I was actually gonna kind of like here. We talked about
that's the thing I was thinking of is, we can have enough optometrists, we can have places for them to go, but if people have gaps in, coverage for eyeglasses, coverage for the services that they need, then we might as well not establish the locations to go to in the first place. So, so we need to have the gaps in care covered, making sure that across state Medicaid programs, across Medicare, making sure that access to eye care is a part of a basic benefit, not those that have chosen the right Advantage plan that maybe has the right kind of coverage, that maybe has the right kind of therapeutics covered after that. So we need to have those gaps filled. So yes, I definitely would promote having those policies taken care of. And that's something that we as an organization pay attention to, is where these gaps are. Where one example is on the rehabilitative side, we're on the ITEM coalition. I don't know if you're familiar with that coalition. It's working to remove a lens exception that is currently in CMS that blocks anybody from getting a low vision device that may use a lens, because they consider that like a pair of glasses. So they won't cover glasses. So anything that uses a lens is blocked. So if you need a seeing eyeglass or something else that's a low vision device, it's blocked right now. So there's a whole coalition of people working to get rid of that crazy little policy. So there's just so much like this that's just fragmented in vision throughout federal policies, throughout state policies, that we're having to grow our government affairs workforce. So, yeah.
The work you guys are doing is so important. The advocacy work, I feel like what I'm hearing from everybody and couldn't agree more about is that there's 3 big issues that are really kind of preventing us from setting up reasonable models of care in our society that would create safety net kind of eye care. It's the lack of reimbursement for telemedicine. It is the lack of any incentives for optometrists or ophthalmologists to work in federally qualified health centers. So like the lack of our involvement in the National Health Service, and the lack of CMS paying for any kind of glasses, meaning Medicare, and setting that standard then for private insurance companies. I think those would be such fundamental changes to the system that seem almost attainable, that would really have enormous impact, and I think would enable all sorts of creativity and things like creating programs for training ophthalmic technicians, or not even ophthalmic technicians, maybe ophthalmic medical assistants. We can make it even easier if we could get industry to help us with some of these amazing autorefractor thingamabobs, right? We could cut out some of the difficulty of, technology can help us make that work much more streamlined. So I think there's just, I guess that's what I'm hearing. And I hope that might be something that Vision 2020 could focus on, is these like core barriers that are kind of keeping us from being able to like move, like scale reasonable ideas that we all have.
Beyond the lens exemption in Medicare, the changes in the One Big Beautiful Bill Act, which pains me to say it that way, is putting a lot of pressure on Medicaid. And so for adults, as states are making decisions how they're going to be managing their Medicaid budget, adult vision care is an optional service. So as they're looking for ways to save money, the optional services are going to go first. So it's another thing to keep track of and be active in your own state advocacy.
Just a real quick comment I wanted to touch on over here. I absolutely think that engaging industry is great, but I also want to acknowledge that over the last few years, industry's been starting to do it. And Genentech's certainly a leader, but we've seen more and more our industry partners who have supported us nationally wanting to get really involved at the community level in meaningful ways. And so I think the thirst is there. Let's continue to feed it.
Can I ask if you can kind of elaborate on industry, the general industry perspective on these programs? I mean, you have this corporate social responsibility or kind of a charity instinct or good, compassionate people, but there's probably a more sophisticated perspective where there's some sense of some, kind of long-term cycling around of patients getting into care or something like that. I mean, you have a big system. How do the conversations go in your back rooms when you think about funding programs like these?
So that's a very broad question. I'll say that I think what we see there's a lot of initiatives going on, but they're not well coordinated. And they don't seem to activate a lot of the people who need the care. And it's all based on a very community level. And within those communities, there's pockets of patients. You talked about some of the zip code information here, and I'm interested in that. But I think within the United States, there are underserved populations that just don't receive the care they need. We're trying to identify how we can reach out to those populations and engage them in a way that they trust, support, and can engage community providers and actually get the care they need. So in order to do that, we have to partner with everybody within that community. And that's with practitioners, payers, community organizers, all of the stakeholders within these markets we need to engage and put together. And that's what we're trying to do. And it's difficult because as you talk, it's so fragmented. And then there's funding, which needs to happen. We're very interested in supporting this, but we're limited in the way we can do it. So I think if you look at all the stakeholders when we come together, there is a common theme that we need to reach particular patients to get care to them. How we do that has to be very coordinated. So, yeah. Did I answer your question? Okay. All right.
Something is like missing here is when we going to have like a new intervention, but you mentioned we have to have like all like stakeholder engagement, which is like this is the gap I'm going to talk about tomorrow as a special session with Dean and Rajeev regarding like how we can move from the data to action. And I'm going to present the ACT model, which is involve all the stakeholders, which is missing, I believe, right now in all intervention. So how the community partner can trust the patient how can trust to the community, how that can trust to advisory board, let's say for patient advisory board. This is something I'm going to talk tomorrow, and this is, I believe, is a gap all like by the how we can bring all together and find the gap. And there is like a 7 step by step, it's a long story, but I am going to talk about tomorrow. But the thing I want to add, especially for the workshop, which I'm going to present tomorrow, is ACT model. We have a two type of the workshop. The first workshop, we are just going to find the gap and like a problem in the community. But I believe if we go for the workshop for the report, for sure we need to engage with the stakeholder, especially from the patient, from the like advisory board. That's why we can like involve them and move forward for the next step, and they can just engage from the beginning of the workshop. And at the final, we can say this is a new intervention. We can go and like move it from the research to the action. So what we have now is from the research side, from the community side, from the patient side, from the health provider. It can work a lot, I believe, for the workshop.
A lot of time what happens is that they go into the community and then they leave the community. And I think that's the trust is not there. So we have to be able to let them realize we're not just coming in and leaving, we're coming in and we're staying and we want to help patients. So a lot of the big issue is trust. They do not trust the outsiders. And because they realize they're an experiment, they realize it's a project, they realize that they really don't care. And you know, we you know, we're talking about Rajeev and I work closer together, and we have a poster that about our community of Rochester, how it's divided, and it's about the affluent people and the non, and how to deploy the mobile vans. And I think they're going to present it tomorrow, one of these days. But even in such a small area, it's so, the gap is so big, and getting in there and getting to work with the patients, it's a big issue.
Two more comments and then we'll wrap it up.
So I'm going to just point really quick. So I'm coming from the vision payer perspective, since I helped to run clinical programs from that side. And I think, you know, everything that everyone's saying today, just about the fragmentation and everything and in the whole system, obviously is very prevalent in the insurance space too, especially when it comes to when you look at vision and medical, right? So, you know, vision plans tend to be carve outs, and they're given so much finances to support those vision carve outs and those health plans. And I think one thing that we're seeing today more so, and it's going to continue, is that optometrists are at the front line of all this vision care. And what we're seeing is when reimbursements are not to their liking, they get out of the network, right? They're no longer part of the Medicaid network. And that's a big struggle for us, is to try to get optometry to be a network, and for there to be enough optometry to help with the access of care that are needed in a lot of these areas. So, you know, I think a big thing is taking this to CMS and asking for more reimbursement for optometry, especially now that optometry is taking on a lot more medical care than it used to in the past, with scope of optometry changing and all of that. So it's just the reality of it. But we do need more support in that area. So, yep.
I'm just thinking more about workforce challenges that are happening here and globally. Andrew Bastaros from Peak Vision just published a paper from Kenya where there are quite a few ophthalmologists, but it's a density distribution issue. And that research has shown that 77% of people will die with unoperated cataract. So they'll never get that cataract surgery, and you know, more are accruing. So I wonder what that statistic is for the US. Density and distribution is an issue everywhere. I haven't seen a lot of evidence around incentives working for people to, you know, relocate, because people have, you know, families. So I think that's been tried a lot in different modalities, but I'm not sure it's been all that successful. However, coordinating you know, private ophthalmologists to visit, you know, their hometown on a monthly basis, using those techniques and using teleophthalmology, and working with, you know, local clinics where there is trust, I think some of those models potentially have been more successful. I was in Cambodia recently, and they had exactly the same problem. Like they have some ophthalmologists, not enough. They're not in the rural areas. So working with the private ophthalmologists, to go back to their hometown was a method that was much more achievable. Obviously, the legislation around who can do what where, that's so critical, and what repayments people get. I don't understand half of the the financing here, but a lot of that is just legislation. I'm not being dismissive of just legislation. Like that's incredibly difficult. It's incredibly difficult to work through. Like it's often harder than some of these other challenges, but it is still legislation, and it just requires the right evidence and the right influence and the right persuasive arguments.
So it's 8 o'clock, so thank you for having a lively discussion. I think the final analysis is that ARVO is not to show me what's right. So where the money is really important, and where it's going is also
where it is also very important. So money speaks volumes, but how do we channel it in the right way, right? And how do we make sure that it's going to causes that actually produce results? And so for that, we need data. We need data that's actionable. We need to focus on a problem that everybody seems to agree that it's really important, and get over our individual differences on it. So tomorrow at 1:15, we're going to be talking about how diabetes may be that initiative, but diabetes seems to be what primary care and what medicine in general feel is important for the eyes, and eye care and diabetes go hand in hand in many cases. We probably see folks with diabetes more than their own primary care provider, especially those with retinopathy and all the injections I do. So I think that's a great avenue to kind of consider, how can eye care work together amongst all our cadres of people to really stamp out diabetic eye disease, and as Kristen Wanu would always say, NTRD, and traction retinal detachment. How do we do that? And so tomorrow at 1:15, we'll have the discussion continue, and a lot of you will be speaking. So thank you again for joining us. I hope this was useful. I hope to have this done next year. ARVO seems a good place that is ecumenical, and it brings a lot of people together. And hope to see you guys here next year when we do it again. I don't know where it is next year, New Orleans. I don't know where we are next year, but hopefully we'll all see you there and have further discussion. Thank you.